I'd help if I unmute. Good morning. My name is Ashley Craiglow. My pronouns are she, her. For a physical description, I am a female with dark shoulder length hair. I'm wearing glasses and a tan sweater. Today, I'm also joined by my colleague Brenda Schaefer-Pellinen with the Arrowhead Area Agency on Aging, and we'd like to welcome and thank you for joining us for today's session on navigating end-of-life care, insights, and support for informed planning. So just a few housekeeping items. We are excited to announce that today's webinar will be accessible to a wider audience. We have arranged for American Sign Language interpreters to be present throughout the session. These interpreters will rotate every 20 minutes, ensuring that everyone can follow along with the content effectively. If you do need those interpretation services, you can click the interpretation button at the bottom of your screen and then click on the ASL. Additionally, we are recording the entire webinar with the ASL interpretation. These recordings will be available on our YouTube channel for later viewing. They will also be on the Ducks in a Row website. So whether you attend the live session or catch up later, you'll have the opportunity to engage with the material in a way that suits your needs. I also encourage you to subscribe to our YouTube channel to keep up with the latest addition to our videos. We're always looking for suggestions for future webinars. So if you have any topics or speakers that you think would be great to have present, feel free to send those to me in an email, or you can also put them in the chat. Please keep your microphone set to mute, and just note that if you experience any issues with bandwidth or audio quality, it often helps to disable your camera. So if you'd like, you can enter your first name and organization or the community that you're from into the chat, and then also what you're hoping to get out of today's presentation. If you have any questions during today's session, please feel free to enter your question into the chat and we'll address those at the end of the presentation. And we'll also take some additional time at the end if we have time to ask questions to the presenters. And then at the close of today's session, you will see a quick evaluation of today's session pop up in your browser. So if you could take a few moments to complete that survey, it greatly helps us in planning our future sessions. And then one last quick reminder is to visit our Facebook page for more information about other upcoming sessions, such as our session tomorrow on having effective conversations about advanced planning. All right, so a little bit about who we are. The Arrowhead Regional Development Commission is designated by the Minnesota Board on Aging as the Area Agency on Aging for planning and service area under the authority of Title III of the Older Americans Act. The Arrowhead Area Agency on Aging is committed to helping older adults maintain their highest level of independence. Area agencies on aging are regional organizations that provide services and support and information for just about everything that older adults and their families could need. Minnesota has 7 AAAs across the state that are local connections to older Minnesotans and the community support they need as they age. The Arrowhead Area Agency on Aging's planning and service area, as designated by the Minnesota Board on Aging, include the counties Aiken, Carlton, Cook, Itasca, Koochiching, Lake, and St. Louis. So I'm going to now take a moment to read our land acknowledgement. So as we support our mission to help older adults maintain their highest level of independence, we do this while being respectful of the space we are being welcomed into by Indigenous people. We strive to deepen our understanding of the multiple ways in which people see and understand land and acknowledge the Indigenous people who have relationships in this land. We also acknowledge the decades of historical trauma, loss, and grief experienced by Indigenous people. It is our promise to not only recognize these truths, but to also take action to show support for our Indigenous elders, neighbors, and friends, and understand our place within the past, present, and future of this land. We know this is just one step in recognizing and honoring the sovereignty of tribal nations. All right. So we are honored to be joined by today's presenters, Sarah Erickson and Rachel Weiner and Tony Lane. I'm sorry. So Sarah Erickson is a senior hospice care consultant with Moments Hospice in Brainerd area. Sarah is certified as an advanced care planning and pulse navigator by Light the Legacy. She holds a Bachelor of Science degree from the University of Wisconsin. She is co-chair of the North Central Aging Providers Association in Brainerd and is passionate about teaching and educating on hospice and advanced care planning. Rachel is the AVP of Business Development with Moments Hospice. She is certified in advanced care planning and pulse navigator. Rachel holds a Bachelor of Science degree from the University of Minnesota Twin Cities and graduated from their mortuary science program postgraduate program. Rachel worked in funeral service for 14 years before finding her calling in hospice care. Her passion is to help families navigate end of life with knowledge, dignity, and compassion. And then we're also joined by Tony Lane, who is an end of life public health nurse. She lives in rural Aiken County with her family and furry friends. So thank you all for being here today. And I'm going to now turn things over to Rachel to start us off.
Thank you so much, Ashley. We are very honored to be here today and to spend this time with you to talk about end-of-life planning. So if you could go ahead to the next slide, Ashley. Thank you. Our objectives for today, what are we going to talk about? Today we're going to talk about understanding the types and importance of advanced directives and healthcare decisions. We'll talk about understanding your choices in healthcare services and long-term care settings at end of life. We're going to recognize choices in funeral planning, be informed on access to palliative and hospice care, and learn to navigate end of life as it approaches. And I know we've got Tony on, who is a death doula, and we're very excited for her portion of the program as well. So we can go on to the next slide. Why are we here today? Because knowledge is power. It really is. Knowledge for our patients allows them to navigate the choices that come along with aging and with terminal illness. Knowledge for our caregivers, which are eventually going to be ourselves, right? A large percentage of people become caregivers later in life. Knowledge for the caregiver helps reduce the fear that they may face during difficult and demanding times. So congratulations and kudos to you all for being here and becoming more knowledgeable and hoping that you can share that knowledge with others. We can go on to the next slide. So choices that we will discuss today. What kind of care do I want to receive when I'm diagnosed with a terminal illness? Who do I want responsible to make my healthcare and financial decisions when I am no longer able to make them? How do I feel about life support or living in a long-term state of unconsciousness? Where do I want to live out the last days of my life or when I can no longer take care of myself? Where do I want to be? How involved do I want my family to be in my care at end of life? When my days are limited, how do I want to spend the time I have left? And how do I want to be memorialized after my death? So hopefully we can get your wheels spinning about some of those questions and hope to fill in some of those gaps for you. So we can go on to the next slide, and I'm going to turn it over to Sarah Erickson to start talking about types of advanced care directives.
Thank you so much, Rachel, and happy to be here today. So yes, we're going to talk about the types of advanced care directives and healthcare decisions. Next slide, please. So April 16th, 2025 is National Healthcare Decisions Day. National Healthcare Decisions Day is recognized each year on April 16th, the day after the date traditionally known as Tax Day, as a way to engage the American public in conversations that encourage people to think about their own personal wishes for their healthcare, particularly at end of life, with the goal of getting people to plan ahead document those plans, and let loved ones know their wishes. Advanced care planning includes three main components. One, completing advanced directives, which are legal documents that provide instructions for medical care. Two, appointing a healthcare power of attorney and a financial power of attorney, who is someone to make decisions for you if you are unable to do so. And three, most importantly, sharing your decisions with your family and loved ones and your healthcare providers. Next slide, please. When you are making your healthcare and end-of-life plan, having a plan means you get to choose where and how you want to live, how your money will be spent, who will make those decisions for you, and who may care for you. You want to ensure that you keep all of your documents and paperwork in a place where your trusted family, friends, POA, healthcare POA knows where to find it. Can't tell you how many times I've worked with families and they say to me, oh, we have a healthcare directive, but it's in our safe at our family home in Florida. Well, that doesn't help you when you're in Minnesota or you're somewhere else and you need to access it. Talk to a lawyer for peace of mind. However, also know that most health and financial directives can be found online and do not require a lawyer to complete. As always, start planning as soon as possible. Don't wait until something happens because it could be too late. Next slide, please. The percentage of adults that complete any type of advanced directive for end-of-life care. How many do you think, what is the percentage you think? It is actually only 33%. 33% of adults complete an advanced directive. As we say, it's always too early until it's too late. Next slide, please. There are a lot of different types of advanced directives, and we are going to talk about those. We have a DNR, we have a healthcare power of attorney, we have a living will, we have a financial power of attorney, we have a POLST or MOLST, and then we also have estate planning, and we're going to talk about each one of these. Next slide, please. When talking about estate planning, this is making a plan in advance, naming the people or organizations you want to receive the things you own after you die, and taking steps now to make carrying out your plan as easy as possible later. So you might have things that are really important to you, whether it be jewelry or furniture or artwork, and you know in your head that you want a certain person to have these things. This is very important to get it down in writing and to have it on paper so people understand where those items will go. Advanced care planning is knowing your voice is heard when making decisions about healthcare. Advanced care planning is the process of preparing for a time when you may not be able to make your own medical decisions. The best time to make these decisions is when you are able to make your own choices, when you are cognitively aware and able to make those decisions. Next slide, please. When talking about estate planning, really the individual that is responsible you're gonna put in charge will be your financial POA. So a financial power of attorney is a legal document that grants a trusted agent the authority to act on behalf of the principal agent in financial matters or other personal matters. A general power of attorney gives an agent the ability to act on a person's behalf in all of their affairs, while a limited power of attorney grants an agent this authority only in specific situations. The principal can revoke their power of attorney at any time and can make it a limited power of attorney. Example, if you're going into surgery or something unexpected happens. If a power of attorney is not removed, it ends with a person's death. So examples of powers people can give to their agent are to use a person's assets to pay for their everyday living expenses. So that could be if someone is going into skilled nursing or assisted living and they need to use their personal finances to pay for those living expenses. Maybe to manage benefits from Social Security, Medicare, or other government programs. To handle transactions with their bank and other financial institutions. To file and pay a person's taxes. Also to manage a person's retirement accounts. Next slide, please. The next slide is an example of a statutory short form power of attorney form. So again, as you can see, it names a principal. It also does allow you to choose what you want an individual to have access to. So someone might have only a responsibility for banking transactions, and that's all that you want someone to do. Or you might choose to have someone do any type of gift transactions or records, reports, and statements. So you can choose what you want your principal to have access to and to be able to do. Next slide, please. Next, we will talk about a DNR, which is a do not resuscitate order. This is a legal document which states that you do not want to be revived or receive CPR if your heart or lungs stop working. A DNR does not apply if you merely have difficulty breathing or are choking. It also does not prevent any other medical treatments. Next slide, please. So this is an example of a do not resuscitate order, okay? So again, this will go through the patient request, the advanced directive living will portion. It will also allow you to choose a medical power of attorney. And it does need a physician's authorization and a witness or notary. Next slide, please. Things to think about. So when you are filling out a DNR, you want to discuss your wishes with your family. If the family fights over your wishes, a time and money consuming court battle could follow. More importantly, arguing over healthcare decisions over a loved one facing end of life can tear families apart. Experience has shown that the more aware family members are of your desires, the more likely they are to be followed, and the more likely the family members are to accept and agree over your wishes. I always recommend for individuals to sit down with their loved ones when filling out end of life arrangements and to talk about it as a family. Talk about why you have made these decisions and who you are putting in charge of specific things. If you execute a DNR directive or you sign a post signifying your wishes for comfort-focused care, caregivers need to be prepared to call hospice versus calling 911 and what a DNR and comfort-focused care means. Ask a healthcare professional or certified advanced care planning navigator to help explain this option to your family and what it means. When someone signs on for hospice, we always fill out a post. And this is something that not only do I, as a hospice care consultant who typically meets with families and talks about and signs individuals on for hospice, but it's also, an opportunity for our nurse to talk about it with families as well. So it's a very large topic of discussion. Next slide, please. So a post or a MOST is a physician or medical orders for life-sustaining treatment. So it's a post in the state of Minnesota. They are portable medical orders that communicate to healthcare facilities and providers a patient's wishes for end-of-life intervention, including emergency medical services or EMS. A post initiative seeks to use one style of form applicable across all healthcare settings. It is signed by a patient or their surrogate and their healthcare provider. It is a legal medical order created for the seriously ill. A physician or nurse practitioner must sign the post in order for it to be valid. So in the post, as you'll see on the next slide, it includes the DNR status. It includes the do not hospitalize status, the do not intubate status, the use of antibiotics, and the use of artificial hydration and nutrition. Next slide. So this is an example of a post. When I am signing on a patient for hospice, I like to go through this in detail because it is a different form. And I like to talk about the different treatments. So again, a full treatment versus selective treatment versus comfort-focused treatment. I think it's very important to explain this form and to talk about what it means, if emergency personnel were to get called. So a great example of this would be if someone is spending their days on hospice at home. If someone was to have a fall and emergency personnel were to get called to that home, if that individual is on hospice, this post order will be posted either on their fridge or behind the front door. And when emergency personnel comes into that home, if they are called, they will look for the post and they will follow what it is that is being asked. So for example, if someone is on comfort-focused treatment, which means they do not want any type of treatment to save their lives, then obviously emergency personnel will not start CPR. Okay, so it's a very important document for someone who is on hospice. Next slide, please. So things to think about. So think about what medical care you do or do not want if you become unable to speak for yourself and there is little or no hope of recovery. One alternative is to think through what you want to happen in various specific situations, such as being placed on a respirator if there's no hope of recovery. Your doctor can help clarify medical questions about alternatives people with your particular medical condition may face. If you would prefer not to focus on the specifics, just think about what you want in general. For instance, if there is no hope for my recovery, I would want to discontinue all extraordinary measures and machines. So do or do not continue to feed me. Next slide. A healthcare directive is a legal document in which you can express your wishes regarding your healthcare and choose another person to make medical decisions on your behalf. They can be short or long in length. They may be changed or revoked at any time as long as you have capacity. So living wills and a durable power of attorney, for healthcare are different types of advance directives. In Minnesota, the living will and durable power of attorney for healthcare are combined and called a healthcare directive. So when does a healthcare POA begin having the power to make decisions for you? And the answer is when you are no longer able to make decisions for yourself. Okay, so whether you are not able to, if you are not cognitive, if you have been diagnosed, for example, with Alzheimer's and are not able to make decisions on your own anymore, that is when a healthcare directive would be active. Next slide, please. This is a wonderful form that is done by Honoring Choices in Minnesota, which is like the legacy. This is a healthcare directive. So as you can see on this form, this is electing a healthcare agent. So you can actually elect more than one. So you can have a primary healthcare agent. You can also have an alternative. Sometimes you can also as well have two primaries, for example. So you can elect to have two individuals that can make those decisions. I always tell people that when you are choosing a healthcare agent, to keep a couple of things in mind. So you will want someone who is who has the same goals that you do, when it comes to end of life and who will honor your wishes. So maybe if someone is very much against, utilizing medical treatment at end of life, putting someone who would want every single, life-saving measure taken, and believes that way is probably maybe not necessarily the right person to put as your healthcare agent. So you're going to want to put down someone who has similar views as you and who will honor your wishes. My other suggestion too is that it does not always need to be family. If you have a very close friend that will honor your wishes and that you, trust to make decisions for you, that is a great individual to put down as a healthcare agent. So it doesn't always have to be family. Next slide. So things to think about when you execute a healthcare power of attorney. So again, choose the person who will act as your proxy with care. It is a very large decision. The person will have to deal with your doctor, the hospital, and possibly your family. Sometimes the individual will have to be aggressive in enforcing your wishes. So you'll want to ensure that you include contact information such as a mobile phone number. When we are looking for a power of attorney, and when we are looking to contact someone, we're going to want to have the individual that is, a healthcare power of attorney is going to want to have access to the healthcare directive, and they're going to want to be available to answer and to sign any appropriate documents. You'll want to appoint an alternate in case your first choice cannot serve or cannot be reached for any reason. The alternate should have the same qualities you look for as far as in the primary proxy. So times when we use an alternative would be, for example, if someone has filled out a healthcare directive and they had listed their spouse as a primary and maybe their spouse is now deceased. So that is when we would move on to an alternative. And so that's an example of when you would move on to an alternative. Discuss what you do and do not want with your proxy and your alternate proxy. The discussion can be just about your general values and wishes. Maybe it's an understanding of your values will help them determine what you want in areas that have not been specifically discussed. If you do have specific wishes, you will want to make sure that your proxy and your alternate know that as well. Next slide, please. So things to think about when choosing your agent. You will want someone who is 18 years of age or older and someone you trust. As I mentioned, similar beliefs and values about medical care and death or dying, or is willing to carry out your wishes even if they are different from his or her own. Is not easily intimidated by family members, friends, or healthcare providers, and/or can make decisions under stress. Can cope with making difficult life and death decisions, including making decisions which would allow you to die. Another recommendation that I do like to give families is that if you are choosing, let's say you're choosing your 2 children, Bob and Sue, to be agents for you. Maybe it's a good thing to have Bob take care of your financials, and maybe it's a good thing to have Sue take care of your healthcare. Maybe not just entrusting one individual to take care of everything. Before naming an agent or an alternative agent, you'll want to talk with each person to make sure he or she is willing to serve as your healthcare agent, to take time to understand and talk about your wishes, and to follow your instructions, and also act in your best interest. Next slide. So once you do have your advanced directives, what do you do with them? So advanced directives are only meaningful if appropriate people know about them. You're going to want to ensure you give a copy to your primary doctor and each doctor who will oversee your care in what could be a life-threatening situation. This includes doctors who will perform an outpatient procedure which involves anesthesia. You'll want to ensure that you give a copy to each person you believe will help enforce your directives. So if you have a proxy and an alternative proxy, each individual should have a copy of that. If you have an online personal health record, you'll want to file a copy with your record. So a great example of this would be, let's just give you an example. If you utilize Essentia Health, they utilize an online personal health record, right? And so you can ask your hospital system to upload your healthcare directive online so that it's easily accessible to Essentia. And then also think about if you were traveling. What if you are, going to Florida for a month or several months? If you had to go into the hospital and use their hospital system there, you would want for the hospital system in Florida to be able to access your online personal health record. And so as long as your healthcare directive is on file online, then they will be able to access that and make your wishes known. Also, carry a card in your wallet to let people know that you have an advance directive and where to find them. Next slide, please. So one of the resources that we use is the Conversation Project. And this is wonderful because what this will help do, it's going to help you understand how to start the conversation with your family, right? And so some individuals, having these conversations regarding death and what you want at death can be a very hard conversation to start with your loved ones, your family and friends. And so this conversation starter guide will really help kind of map out how to have these conversations. And once you do have these conversations, what you need to do from there. Next slide. Another great resource is 5 Wishes. 5 Wishes is a wonderful document that really goes into detail as far as what you want at end of life. It's written in everyday language, making it easy to understand and complete. When I have used this with patients, I will tell you that a lot of times I will sit down with them, we'll go through it line by line, and then I'll say, let me come back to you in a couple of weeks. And let's, you want to let it marinate a bit. There's a lot of things that are covered in 5 Wishes. And like I said, it's a wonderful document, but it is long and it does go into a lot of detail. So it may take someone a while to fill this out. It covers personal, spiritual, medical, and legal wishes and all in one document. It allows your family or caregiver to know exactly what you want so they don't have to guess. It is legally valid in nearly every state. Next slide, please. And then we do also have some local advanced care planning in-person events. So these are a couple of events that we do have coming up. I know that up in the Superior area, they are doing a POA party for National Healthcare Decision Day. This is actually going to be April 16th from 3 p.m. to 7 p.m. at the Superior Public Library. You will be able to fill out a healthcare directive. They're going to have individuals there to witness. So this is a wonderful opportunity to talk about, get information on regards to your healthcare directive, and then also to fill one out. And then if you want to view a list of in-person workshops across northern Minnesota, there is a link here for Ducks in a Row, and that will let you know what is going on in your community. Next slide, please. So next we are going to talk about options for support at end of life: home care, home health, and long-term care. Next slide, please. The Patient Self-Determination Act, PSDA of 1990. PSDA requires hospitals and other healthcare providers to inform patients of their right to make decisions about their medical care. It also requires that patients be given the opportunity to create advance directives. What does the PSDA do? It informs patients. It requires healthcare providers to inform patients of their right to make decisions about their medical care. It requires healthcare facilities and companies to make note of healthcare directives if a patient submits one. It also requires that patients be given written notice upon admission to a healthcare insurance or care agency of their decision-making rights. It also protects patient rights. It prohibits healthcare providers from discriminating against patients who create advance directives. It ensures that patients know they can facilitate their own healthcare decisions and that they have the right to accept or refuse medical treatment or suggestions. So who does the PSDA apply to? Hospitals, skilled nursing facilities, hospice organizations, home health organizations, and health maintenance organizations, or HMOs. Next slide, please. Hospitalizations. So according to most research, around 9 out of 10 people, or roughly 70 to 80%, express a preference to die at home, meaning the vast majority of people who would choose to spend their final days in their own home if given the option. However, most people die in the hospital. In fact, only 20% of people die at home. Some key facts about end-of-life hospitalizations. A large percentage of people nearing the end of life are hospitalized at least once in the final months, with some studies reporting rates exceeding 60% within the last month of life. So what kind of impact does that have on your quality of life? Frequent hospitalizations at the end of life can disrupt a person's desired place of care, potentially causing stress and discomfort for both the patient and the family. Next slide, please. Care at home. Home care versus home health. With home care, it is unskilled care by caregivers, paid out of pocket or covered by long-term care insurance or Medicaid. There is no eligibility criteria. The length of care is as long as needed based on a patient's budget. There is in-depth health with everyday tasks, such as caregivers visits for up to 24 hours, meal prep, delivery, cleaning, laundry, household chores, transportation, companionship, help with toileting and transferring or moving around. We utilize home care with a lot of our hospice patients, especially if they're staying in the home and maybe they don't have a full-time caregiver to help with additional services in the home. The lovely thing. Home health is skilled care by nurses or therapists, and it is covered by Medicare, Medicaid, private insurance, and a patient must meet criteria. There is a length of care depending on need. They need to meet eligibility and doctor's orders. They will have nursing, therapy, medical social work, some home health services, and a team visits a few days per week based on doctor's orders. This can also include IV therapy, injections, medication management, medical testing and monitoring, and medical tests, pain management, and wound care. What do both have in common? The goal is to keep patients safe and comfortable in their home. Care in a home-like setting, help avoid unnecessary hospitalizations, and delay facility and nursing home level of care. Next slide, please. Care in a community setting. So these are types of long-term care communities. Assisted living. So this is assistance with activities of daily living, medication management, healthcare monitoring. They also do housekeeping and laundry. They will have a lot of recreational and social activities like bingo or happy hour, 24/7 security, scheduled transportation, and most likely 2 or more meals a day. So it is independent living with services, okay? Next is skilled nursing. So this is oversight by a physician. So it is typically 24/7 RN in the building. So there is a registered nurse at all times. I love happy hour, yes. Yes, there is happy hour in assisted living, yes. But when you are in a skilled nursing setting, typically the nurse is in the building 24/7. So there's always a registered nurse in the building. There are also recreational and social activities, so they will still do a lot of things like bingo, happy hour. It could be field trips, getting out. They also have social work and pastoral care. So most likely in those settings, they would have a chaplain in their facility. Most of the time there's 3 meals a day with snacks and housekeeping, laundry. They also have PT and OT, so physical therapy and occupational therapy. They have speech therapies. They have 24/7 security. And then they also do respite care and inpatient care for hospice. So if someone, respite care and inpatient care would be when someone is maybe at home and their primary caregiver needs time for respite, needs some time for themselves. We can contract with a skilled nursing facility so that individual can go into a skilled nursing facility. Hospice can still go into the facility and manage their care, but they are under the supervision of a physician and an RN. A hospice house is a medical care facility in a home-like setting. It is staff trained in end-of-life care, more room for family, typically with food and sleeping accommodations. So a lot of times we'll see with a hospice house, the rooms look very different. So it may have a room for the patient, and then maybe it would have a living area with like a couch and a TV, so that when family comes in to see their loved ones, knowing that they are on hospice, they have places to be. So it's just a different environment. And also there's skilled nursing and assisted living facilities that will also a lot of times have hospice rooms. So they're rooms that are specifically created for hospice settings that, again, just have additional space for families when they're coming in to see their loved ones. So again, they typically have help with food and sleeping accommodations for families. It's more of a calm setting. So, when we have patients in a skilled nursing facility that are on hospice, just think about all the busyness that's going on, right? You have people wheeling down the hall in wheelchairs, right? You have the nurses on the med cart. It's not the most always calming environment for someone who is on hospice. So a hospice house is a really great option with just a more calming atmosphere. Meals, snacks, housekeeping, laundry, those are all done by the facility. It is mostly private pay with limited help from Medicare. They use chosen or contracted or their own hospice company. So in order to go into a hospice house, you would need to be already on hospice. And then also memory care. So this is specialized housing and care for residents with cognitive impairment or dementia. It has 24/7 supervision, memory care staff trained to understand dementia and support residents. There are therapeutic activities to soothe and improve cognitive function. They will also have secured entrances and exits, and then they will provide meals, snacks, housekeeping, and laundry. Next slide. So these are some resources for helping older Minnesotans, right? So there is the Minnesota Senior Linkage Line, and they provide wonderful resources for individuals to plan ahead for what they want for their future. So again, you can see here with housing resources, they'll talk about your health insurance and Medicare, medical assistance, and the forms needed for all of that. Financial assistance. They will also provide you with community support. So if it's someone who is choosing to stay at home and they need a monthly drive into Brainerd, for to get their prescriptions or to go to the doctor, we can set them up with transportation in order to get there. Another really important one is meal delivery and prep. So individuals that maybe are choosing to stay at home and maybe it's becoming harder and harder for them to to cook meals, and we want to ensure that someone has proper nutrition, setting up a meal delivery and prep for them to come in. And then also legal assistance. So helping individuals with putting together a healthcare directive, estate planning, and then also fraud. Next slide, please. So veterans may be entitled to health benefits, right? So, you want to complete an application for health benefits and submit along with these forms with benefit summary, financial information, and a copy of other insurance. So if you are a veteran, please know that there are a lot of resources available for you. Utilize these resources. There's just, they offer a ton. You want to go online to www.va.gov, and they have just a plethora of resources. The County Veterans Service Office is also, another opportunity to, to get in touch with a veteran service officer that can help you with what you're eligible for. Another resource, next slide, is the Fond du Lac Band of Lake Superior of Chippewa. And so they will provide assistance for enrolled members of federally recognized tribes and their children and grandchildren. So this is a wonderful organization that will help with resources for the tribal community. Next slide. And now I'm going to pass it over to Rachel Wenner to talk about funeral planning. So thank you very, very much.
Thank you, Sarah. Hopefully everybody can hear me okay. We'll go ahead to the next slide, please. So funeral planning, what it entails. So first off, understand that there's a difference between at-need planning and pre-planning a funeral. At-need planning occurs after the death has taken place, and pre-planning is done beforehand. At-need planning is done all the time. The funeral home can absolutely arrange everything down to the very last dinner roll for a funeral or memorial service at need. And typically when a death occurs, you call the funeral home, right, or the hospice organization, and they call the funeral home for you. The funeral home will come out and do what we call a removal, bring the body back to the funeral home, and then typically you would meet with the funeral home either that day or the day after or whenever works for the family. Funeral directors are amazing resources. They have done this 100 times, and they can plan absolutely anything for you at need. Okay, that's their job. So don't feel like if you haven't planned something down to a T that you're lost by any means. Funeral directors have lots of resources. So, but pre-planning is done ahead of time, and it creates a remarkable peace of mind. It really limits the burden on family members during a very difficult time. And studies show that it actually saves the family money. Yes, that's right. It saves the family money. So when pre-planning, consider involving loved ones in discussions about your preferences to ensure your choices are understood and respected. It can also help them feel more comfortable when their arrangement time comes. So I can't tell you how many times I've sat down at a table with a family and maybe their mother or father never talked about death, never talked about their funeral. And I have to tell you, it's such a more difficult conversation and navigation through that time versus a family that comes in and says, Mom told me exactly what she wanted. I know she's got her arrangement down here. We talked about it all the time. I feel great with what direction we're going in because we know that that is what her wishes were. And again, it's a completely different conversation than when somebody's lost and in the dark, okay? It calms the family, it gives them reassurance, it gives them peace of mind when they know it's been pre-planned and everything's ready to go. So while pre-planning allow for thoughtful consideration, it's essential to regularly review your plans to ensure they still reflect your wishes and adjust for any changes in circumstances or preferences. For example, as a mother right now, myself in the workforce, I have a living family, I've got young children. Now I might decide that having an open casket and potentially like a 2-day visitation in a church might be the way that I wanted to go personally. However, as I age in the future and, my kids get older, my social circle fades, maybe later in life, I lose a lot of family and I lose a lot of friends. Maybe I don't do a 2-day, visitation with open casket. Maybe now I turn to a direct cremation. I mean, big changes like that happen for people. And just know that it's okay to change your plans, but just make sure that you're documenting it. So documentation. So in addition to sharing your wishes, also consider using a legal document like a will or a directive that includes your funeral plan. So yes, you can tell people your wishes, but it's a whole nother thing to write it down. So we all know that a healthcare directive ends on death. However, if you put funeral plans in a healthcare directive, that absolutely still will be followed if it's on file at the funeral home or your family has copies of that. So if it's signed by witnesses, we will still follow those funeral plans that are laid out in the healthcare directive. You can also go down to the funeral home and make a whole pre-arrangement plan with the funeral home and sign things. You can sign actually to have your body cremated, which is nice to have that already signed. If you have a big family, we actually ask for almost all of your children to sign for a cremation. So it's really nice to have that already signed by the decedent already because it's just less tracking down of people to get signatures. So just know you can keep all of that pre-signed and ready to go at the funeral home of your choice. And you can always change your funeral home last minute. So just because you pre-planned with a certain funeral home does not mean you have to use that funeral home either. You can change it anytime. I was in a small family funeral home in a small town, and if people moved, I would get calls from other funeral homes saying so-and-so has moved to this new area. Maybe it's Florida, maybe it's just another town in Minnesota, and we would happily send their pre-planned arrangements over to that other funeral home. So don't feel like you're limited to the funeral home that you pre-arranged with when the time comes to use the funeral home. So pre-funding your funeral. So research reputable funeral funding options or burial assistance plans that cover costs. I like to talk about that, but most funeral homes do have really great pre-planning and insurance folks available to you. And they usually do typically have about the same rate. And I'll talk about funeral insurance policies here in the next couple slides. So choosing a funeral home, visit potential funeral homes in advance to meet with staff, tour facilities, and discuss pricing options, ensuring you feel comfortable with your choice. There are national options, so I can think of like the Neptune Society or maybe even just the Cremation Society of Minnesota. Those are inexpensive cremation options. I would call there, and also they have consultants who will come to your house. Funeral homes will come to your house. You don't always have to feel like you have to go to a funeral home to pre-plan. You can call and discuss options with them over the phone or ask them to meet you at your home or a place that's convenient for you. Think about any cultural or religious practices that may influence your decision. Discuss it with your family and please take into account their preferences and expectations as well, remembering that our funeral is for those left behind and not necessarily for ourselves. It's really good to explain your preferences to each other openly, maybe at the dinner table one day, and just know that everybody's on the same page with planning the funeral. And also think about personalization that you could bring to your funeral. Songs, special readings, involving friends and family to participate in creative ways. Creating a unique and personalized experience in a funeral is something that your family will never forget and they'll keep with them always. So we'll go on to the next slide. So planning your disposition, funeral, or memorial in advance reduces stress and anxiety for your loved ones and allows them to grieve without worrying about the decisions they made. So I cannot stress that enough. That's why we're going to say that multiple times during this presentation. Pre-planning reduces stress and anxiety. And again, I will point out it does save money at the end of life as well. Studies have shown. Also avoiding conflict. You'd be surprised if I told you how many times that I witnessed conflict at the funeral home during planning. When things are pre-planned, you do not see that conflict. It really is an amazing thing. Next slide, please. Choosing a funeral home or memorial provider. I know we're getting short on time, so I'm going to go through this slide pretty quickly, but take account of the funeral home's reputation. Lots of people choose local funeral homes. Again, there's national funeral homes funeral entities that you could go through. You can always, whenever somebody dies, maybe outside of their local town, you can always call your local funeral home. And even the funeral home in town, it really doesn't matter. I think people kind of get hung up on who they pre-plan with, but funeral homes work a lot together. So if a person dies in a specific area outside of their hometown, if they called the local funeral home in that town and you told them that you're pre-arranged with your hometown funeral home, they will coordinate with that funeral home and do all of the kind of back conversations for you. I guess kind of making sure that you don't have to make extra phone calls. In that same regard, if you called your local funeral home that you pre-plan with, which is not the city that maybe the person died in, they would also work with that local funeral home just to get somebody out there sooner rather than later. So again, don't be worried about who you necessarily pre-planned with. Just call the funeral home that's convenient and let them know potentially where you might have a pre-arrangement. Again, funeral homes work together. So consider services, consider cost. Cost is a big thing nowadays, especially with direct cremation, and location. So not all funerals are happening in, the churches or the funeral home like they used to. You can be creative. Really, any place can be a place for a funeral or memorial service. So we'll go on to the next slide. The funeral rule. I like to point this out because this is really important. The funeral rule was created by the Federal Trade Commission, and it gives you the right to buy only the funeral arrangements and items you want. When you're working with a funeral home, you do not have to accept big packages. You can get kind of more of like an a la carte style. You can call a funeral home and get information on pricing over the phone. Or if you go to a funeral home and ask for price lists, they are required by this rule to give you all of their price lists. You can see a casket price list, an outer burial container price list. Again, you can call and get that over the phone. And you can use an alternate container that you purchase outside of the funeral home. So I know Costco, believe it or not, sells caskets online. So you can make an earn out of anything. So just know that you have the right to bring in your own items to the funeral home. I just always make sure people know if you're getting a casket from any place other than the funeral home, just remember quality. So we can go on to the next slide. So, so the Medicaid spend down. So we all know that the cost of living at end of life, especially if somebody's in long-term care or they're utilizing home care in the home and paying privately, it can get really expensive. And as we go on and on, our money dwindles, right? So when you look at filing for county assistance to help with your healthcare costs or your living costs at end of life, or as we age, the county will kick up and assist with those expenses, but they do require limited funds. They don't want you to live on nothing or be impoverished. However, a really great resource for when you're getting to that point where you're thinking, the money might run out, it's a great time to call the senior linkage line. They're experts. They can connect you with people who can educate you on what that spend down looks like. But just know, investing money in your funeral is not is not a part of that look back of the 5-year period for that spend down for the medical assistance application. And so what that means is putting money aside in a lump sum for your funeral is a really good idea when you're applying for medical assistance, because you don't have to spend that money down. You can put it towards your funeral. That way your family doesn't have the potential burden of the financial when the time comes for the funeral. So because as we all know, funerals can cost anywhere between $3,000 for a basic or direct cremation to sometimes $15,000 for a traditional funeral. So again, the cost can be pretty high. So in order to put this money aside to our funeral home. You can't pay the funeral home a $15,000 check and just expect them to keep it. Instead, we actually make sure that that money is safe, because again, a funeral home could go out of business and keep your money, right? So what they do is we put it in a funeral irrevocable insurance policy. And this insurance policy, once you deposit the money, makes interest, right? So we hope that the interest in this insurance policy is more than the rate of inflation, right? So the money will gain money. And even if the cost of services and items goes up, that insurance policy will have the money to cover all the things that you itemized in your pre-planning funeral plan. In order to create a irrevocable funeral policy, you do have to have an itemized plan that is signed by a funeral director, and you do submit that with your insurance policy. So we can go on from this slide. Just know that if you are a veteran, you do have burial and death benefits through the VA. Again, Sarah touched on it, but it's really important to connect with your county veteran service officer right away when you're a veteran to know what you're entitled for. You could be entitled to amazing health care benefits in the home, VA home benefits, nursing home benefits. They have awesome hospice benefits. They have something called concurrent hospice, which also lets you get curative treatments along with hospice if you're a veteran. There's just a lot of great benefits. I don't have to go through them all individually, but please contact your veteran service officer, have a copy of your DD 214, and know that you deserve extra benefits. So we'll go on from here. I know we're at the 11 o'clock hour. Just wanted to go over quickly. There's lots more options other than just a burial or cremation. They do have alkaline hydrolysis in the state of Minnesota. We are actually the first state to have this form of disposition. It's a chemical and liquid process of disposition. It uses water and heat. It's a lot less toxic than maybe the ashes that are created from a crematory. There's no greenhouse gases created, and it was actually pioneered by the Mayo with their body donation program. So you can look for that. Some of the big funeral homes in the state of Minnesota have alkaline hydrolysis as a form of disposition. And again, it is less greenhouse gases than cremation. There's also green burial, and this includes no embalming. Usually the body is buried in like a wooden casket, or it's wrapped in a shroud based on the preferences of the cemetery, of course. There are multiple green burial cemeteries in the state of Minnesota, and more funeral homes as well that are doing green burials. So please look into that. There's a lot, probably more in the metro area in Minnesota, but it is growing, absolutely. There's also body donation, and there's a couple slides here. There's the University of Minnesota Anatomy Bequest Program, and then Mayo also has a donation program. And then also just I wanted to put this on here that Minnesota legislature in 2004 passed natural organic reduction in the state, which means it's basically known as human composting, and where the body goes back into soil. You can have that soil and bring it back to maybe make a memorial garden, or you can donate it. But again, it's a very, I guess, earth-friendly form of disposition, and it's been pioneered over in the western states in like Oregon and Washington area. It started, and it's coming to Minnesota July 1st. So things will be changing in the funeral world, obviously more in the years ahead. So we'll go on to the next slide. So I just put these in here. Again, if you're going to think about body donation, it's very important to pre-plan. You have to have an application into the university or Mayo ahead of time. You have to have gotten an acceptance letter from them. And even if you are accepted to one of these donation programs, there could be a chance that the body is not accepted at time of death, based on whether or not the body had infections, or just their, I guess, how busy they are. So just know that if you do have even a donation, acceptance letter and everything in place, please do have a backup plan. But these are wonderful programs. Doctors, dentists, all kinds of different medical programs learn from these body donation programs. It's really valuable for our state and for entities like the Mayo. So you can go to the next slide, and you'll get a copy of this PowerPoint as well after this presentation. So you'll have this contact information, but there's the Mayo program. So you can go to the next slide. So I'm going to touch on hospice and palliative care very briefly. I'm sorry about that. I will stick around for questions if anybody has any, but we'll just touch on this briefly so we can go to the next slide. So hospice and palliative care. So palliative care is the umbrella term, and hospice care is a form of palliative care, and it is specialized medical care focused on relieving symptoms and stress of a serious illness. If you have a serious illness or a disease that has complications or symptoms, you can get into a palliative care program. Palliative care programs vary throughout the country at what they offer. Most of them are outpatient, so you're going to a clinic and seeing a special sector of doctors in the palliative care world, whereas hospice is a program specifically designed for people with those terminal illnesses that have a prognosis of 6 months or less, although we don't have a crystal ball, right? We do have people on hospice. For example, my grandfather was on hospice with us, and he stayed with us for about 3.5 years on our program. So we never know how long somebody's going to be on hospice, but the program is designed for people with a prognosis of 6 months or less, and it really is a holistic end-of-life program to help people relieve the symptoms that they have with their illness and to help them pass away peacefully and have comfort. It's also there to support the family. And actually, patients enrolled in hospice care live on average 29 days longer than patients not in hospice care. So that's a really big deal. Actually, patients with cardiac disease live on average 81 days longer when they have hospice support. So really good things to think about there. We reduce hospitalizations, doctor and ER visits. Hospice care comes to the patient wherever they call home. We can go on to the next slide. So again, just some differences with hospice and palliative care. One big thing is that with palliative care, if you're getting some symptom and disease management, extra care from a palliative care team, you can still be doing full curative treatments. With hospice care, we're taking the comfort approach, right? Just to that terminal illness that we bring a patient on for hospice care, hospice is taking over that disease. So cancer patients, for example, are done with some of their really aggressive chemo and radiation treatments before they come on to hospice services. However, with our cardiac patients, you could absolutely keep on your cardiac medications. It's just we're saying we're not going to go in for that open heart surgery or get those stents placed. We're also not going to be bopping back and forth from the hospital. We're going to stay home and stay comfortable, and we're going to depend on our hospice team to make us comfortable. So again, you can get curative treatments on palliative care, whereas with hospice, those really major curative treatments have stopped. And then also that prognosis of 6 months or less should be there for hospice care. But again, one of the really main important differences is that hospice care is covered 100% by Medicare A, by the VA, by Medicaid, by private insurance. And if you don't have any of those things, if you don't have insurance or Medicare, Medicaid, find a hospice organization that will do your care pro bono, because there's so many out there. So it's a great free program for people who qualify for it. So go on to the next slide. Hospice philosophy, I just talked about that. It's comfort care, and you guys will get this presentation. So we'll go ahead and move forward from here. Two more things I want to point out about hospice before we move on and pass it on to Tony is that we have a whole team of professionals that are helping people remain in their homes and remain comfortable. We have a medical director, RNs in the field, certified nursing assistants, spiritual care, social work, bereavement counseling after the death happens, dietary aids. We have therapy that we can contract with for specialized situations, depending on the plan of care. So we come around the patient and the family. We're there to support the family. We're not 24-hour care. We do routine visits based on need of the patient. So again, the person does have to have a primary caregiver or maybe be in a home or assisted living or nursing home that has additional care 24 hours, but we are supplemental care and we are 24/7. And if there's a change in condition, pain, or symptoms to be managed with their patients, call hospice, and we're going to be there at bedside. So you can go to the next slide. Hospice facts. So just real quick, unlimited benefit to those who are eligible. So just like with home health that has an end date, there's no end date for hospice. So as long as the patient qualifies, like I said, unfortunately, sometimes we only get a patient for a day or two, but sometimes we get them for years. So as soon as you qualify, talk to a hospice professional. Even just have a consultant from any hospice come out and talk to you about services, do a chart review to see if somebody would qualify if they've got a disease and they are declining, getting infections, being hospitalized over and over. It might be time for hospice. So talk to your physician, to your healthcare provider about whether or not it'd be a good time to make a referral. But also you can call and talk to hospice anytime. Most hospices have consultants that will come out to your home, just like a funeral home would, just to talk to you about options. So the patient does not have to be a DNR to be on hospice. I think that's a big misconception. You can revoke services at any time. So if you decide, oh, nope, I want to do curative treatments, or I always tell people when they sign on to hospice, you can fire us at any time. Well, we haven't had that happen yet, but if somebody changes their mind and wants to go another direction, you can absolutely come off services at any time. I talked about it, including the care of the family. Education of the family is also key, letting them know what's ahead, how to best care for their loved one who's declining. That's what we do. We also cover, medications associated with the hospice diagnosis and any medications for comfort, pain medications used for like constipation management, things like that. We pay for equipment, specialized equipment for the patient, oxygen, hospital beds, those types of things. And it's really a wonderful, wonderful benefit. So you can go on from this slide. And just there's some common objections. I won't necessarily go over the objections, but I don't want to give up is something that we hear a lot. You can go on to the next slide. I'm not ready. Again, nobody's ever ready. I don't want to go on hospice. I want to stay home. We're here. We're open. You do not have to say you're ready to die. You do not have to say you're ready to give up hope to be on hospice. We are there to support you and hold your hand through the journey. Gone from My Sight, a wonderful book of books for end of life by Barbara Carnes. She's an award-winning end of life educator. She was a hospice nurse for many, many years. Wonderful set of books. We give them out. Our hospice gives them out for free. You can always call us if you want a copy or order them online. It's just a wonderful resource. So I think that is it for me. All right. Thank you. I'll turn it over to Tony.
Okay. Hi, I'm Tony Lane. I am an end-of-life doula. I'm also a public health nurse, and so that is my background. I work with 65 and older in Aiken County, and I will try to make this very quick as we are already way over time. So next slide, please. So what is an end-of-life doula? An end-of-life doula is there to help the terminally ill and their loved ones through the transition from this world to the next by advising and supporting the dying and their loved ones in what way is best for them. So it's providing non-medical support to the dying and their loved ones through the last days of their life and assisting people in finding meaning, creating a legacy project, and planning on how the last days will unfold, and then offer assistance with closure after the death. So it's emotional, spiritual, and pragmatic support. It's asking the question of the person who's dying, the whole family, what does a good death look like to you? What do you want to do with the time that you have left? Just as it takes planning to have a good life, a good death also requires planning. Next slide. So there's 3 phases in the model of care. The first one is a life review and legacy. We're talking about exploring accomplishments, formative moments, values and beliefs, life lessons, and working through some of that. And then legacy work, which is maybe planning something. A lot of people's concern when they're dying is, will I be forgotten? And developing a legacy is a project that can offer extremely rich and deeply meaningful opportunities for a dying person to engage with their life, address unfinished business, and leave behind something that helps loved ones continue to connect with them long after their death. It could culminate in a book or a video, a walk in nature, written letters to loved ones, a photo collage, a scholarship for grandchildren, etc. And then planning the vigil, which is as simple or as detailed as people want. The vigil plan incorporates the wishes and personalities of the dying person, the needs of the loved ones, and elements of their culture, tradition, and life experience for them to make choices specifically how they want to be honored during their last days and moments of their life. For example, how medications will be managed, who they would like at the bedside, et cetera, et cetera. And then the last part is the reprocessing and early grief. Next slide, please. So a doula comes alongside the family and the person with the terminal illness and helps to develop these things, can kind of fill in the gaps and provide support in whatever way the family would like. Next slide, please. So benefits of doula care is, again, like I said, they can kind of fill in the gap. It's like water flowing to the area of greatest need, help with making wishes or better attention to the wishes, help with support for the family as well. And emotional support, again, like I said, it's non-medical, so it kind of fills a different role than hospice. And next slide, please. And the next slide for purposes of brevity. Okay, so a lot of what we do as death doulas is listening and helping to hear what people really want. Maybe some guided imagery, can be some massage, music and reading, attention to the spiritual, whatever rituals are important to the family or the person with the terminal diagnosis, and mapping of emotions. All of those are, I could go into more detail, but we don't have time. So it's helping to teach loved ones what dying looks like, and helping when need be to help make sure those wishes are honored. So the next slide, please. So I've gone through the INELDA 30-hour training. There's some certification process, and I work through Aiken County Care here in Aiken, but I know that there's end-of-life doulas in the Duluth area. There's some up in the Grand Marais area. I'm not sure where else, but it's just another piece of the puzzle that can be just really helpful for families and people with the end-of-life diagnosis. All right, that was extraordinarily quick. I hope that gave you just a basic understanding of what end-of-life doula can do. And yeah, if there's any questions, just let us know. Be here for a few more minutes. Thank you.
Thank you so much, Tony. We really appreciate you going through that. And like Tony said, if anybody has questions, feel free to put them in the chat. Otherwise, if you want to hang on for a little bit afterward, we can chat some more. But for time's sake, I'm just going to close up the session. So thank you all for participating today in this presentation on navigating end-of-life care. I want to thank our presenters, Rachel and Sarah and Tony. We do have a few more upcoming webinars about advanced planning. So Tomorrow we have effective conversations on advanced care planning. And then on Thursday, Justice North will be presenting again on safeguarding your health, the essential guide to healthcare directives. And then here is our agency contact information. After the webinar, you will receive resources that were talked about today. You will receive a copy of today's presentation, as well as the link to the recording so that you can go back and rewatch if you need to. And if you have any questions, you can email me and I can reach out to Rachel and Tony for you to get those answers. So thank you all for attending today. We appreciate it and have a nice day.